tengo el tremendo orgullo de presentar a la doctora Keating, quien también va a incorporar algunas de las ideas y las preocupaciones de la doctora Yolanda. Gracias por estar con nosotros y por compartir con nosotros el modelo canadiense.
So I want to thank Felicia very much for the invitation to come and talk to you today. I think it's a very important discussion that you're having that's addressing the healthcare needs of breast cancer patients, and this particular session with its focus on survivorship. I'm a radiation oncologist, so I'm bringing, from Canada, I'm bringing a Canadian perspective, one of many perspectives, I think, in Canada. But I'm a radiation oncologist at a very, very large specialized cancer hospital, Princess Margaret Hospital. And I also come from a medical education background. I hold a number of positions in the hospital that relate to leading the survivorship program, the patient education program, the medical education program. So I suppose it's not particularly a common approach, but I want to talk about survivorship from that perspective. A few points about the Canadian healthcare system. I found a lot of similarities really in hearing the previous presenters talk. We have a huge vision for universal access to healthcare, and that vision is challenged by our geography, as I've heard Mexico is. I mean, we're a huge land mass, and trying to get patients to places to provide healthcare is a big problem. We have resource inequities between our urban areas and our rural areas, and many jurisdictions really trying to look at alternate strategies, telehealth, e-health strategies, to try to get help out to where it's needed. The delivery of healthcare really is a jurisdiction of the provinces. We have 10 provinces and 3 territories, and so there are have and have not provinces. So while we hope to have similar programs and services for patients, that's just not the case at the moment. We're a very multicultural country, so diversity of cultures, of language, health literacy. If you're going to engage patients as partners in their care, we really have to address issues around health literacy, and these are challenges for us. And then there's the difference in the federal and the provincial mandates, as I've mentioned. Federally, for cancer control, we have an organization called the Canadian Partnership Against Cancer. And this really is a partnership of engaged stakeholders who are really trying to set the vision for quality cancer care in Canada. And then they're setting system metrics, and then doing an analysis of how well in the provinces that we're doing. They do not have metrics for survivorship care at the moment, although they're starting to talk about it. Really, my hospital is in Toronto, Canada. It's in Ontario, and so the jurisdiction that's involved in funding healthcare for my patients is Cancer Care Ontario. And really, originally, this was an organization that funded diagnosis and treatment of cancer in comprehensive cancer centers. And I think we've been significantly influenced by the dialogue about survivorship that came out of that report from the Institute of Medicine in 2005. In 2008, we got around the table and started talking about it. And this really is now, if I can make the this is now really the latest edition of the cancer journey that Cancer Care Ontario as an organization is trying to support. So we started in this box, we've added prevention. Screening programs for breast cancer have been in place for 20 years in Ontario. But this is the box, recovery and survivorship, that really wasn't there if you looked at this map a couple of years ago. Important to note also that end of life and palliative care is very much part of the thinking. What's new is this used to be just for the cancer centers. Now it's looking at the cancer control from the primary care perspective. And this, which you can't read because it's all fuzzy, but says psychosocial and palliative care. What it's missing, which I've heard you talk about, is the integrated cancer rehab. And I think that in another couple of years, we're going to see another bar down here where we start to get all of the necessary services together to deliver cancer care well. From the point of view then of the components of survivorship care, as we've evolved in Ontario in terms of delivering quality cancer care. I think that we have accepted that there are 4 platforms that we need to address for our survivors. Identifying and managing the recurrent cancers, second primaries, which are often treatment-induced, and the persistent and now late side effects of cancer treatment. As a specialist looking at this, I'll say, yes, that's what I do all the time, except perhaps not actually very well, because I would tend to focus on the physical side effects of maybe just the treatments that I give. And I find that the discussion here has been a more enlightened one about what the problems people face. And I like the City of Hope model that frames the various categories of problems, because it really pushes us. I may not have the skills really and the resources to do this, but it's really starting the conversation. The second platform is to optimize health. And this really is about preventing or reversing side effects. And this might be an area of active research with our biological researchers and regenerative medicine. But really, in the formal cancer program, prevention isn't part of our mandate, and we really would look to our primary care colleagues to help us out in that regard. Certainly health promotion, which is around preventing the recurrence of cancer, preventing new cancers, and maybe even reversing side effects. Again, we would want to look at our primary care colleagues. And this, of course, requires some coordination and systems and processes of care that we don't currently have in place. So Cancer Care Ontario is now starting to look at setting in place some of the systems that would help us coordinate care with the specialists, the primary care physicians, the family health care teams, and all of the supportive care specialists and allied health workers who can help us actually achieve good quality of life and medical care for survivors. This, of course, will definitely require an organized plan to keep everybody knowing what their roles and responsibilities are. The final plank, which is kind of small print within the IOM document, is really survivors taking responsibility for their ongoing day-to-day health issues. It's really talking about self-management approaches, again, guided by self-management support and an organized plan. So there's a couple of demonstration projects in Ontario right now, because there's a fair amount of evidence and guidelines and work done in breast cancer, as you've heard, that says that perhaps a shared model or a transfer of care to the family practice units, the family health units in low-risk breast cancer is an appropriate thing to do. So we're engaged in a pilot to see if we can figure out how we might change the way we do business to the way we ought to do business. And so specifically in breast cancer, we're asking the family doctors now to identify and manage local and systemic recurrences, identify treatment-induced second primaries, which are not that frequent in breast cancer care, and then also help us out with the long-term medication adherence, the long-term tamoxifen and hormonal therapies. We would make this transfer at about 2 years. The whole list of potential treatment-related complications is a challenge because we can't really give them guidelines about the risks of people getting these and what to do about them. And I think that there's huge resource challenges in the community to get special help to try to ameliorate some of these particular symptoms, which I've listed here. Optimizing health in terms of treatment for treatment-induced menopause, fertility issues in young women with breast cancer, sexual health and body image issues, again, would become the mandate of the family health teams. We've heard about all of the health promotion activities that have to happen with weight reduction, physical activity, alcohol, smoking cessation programs, healthy dietary choices, and then cancer screening for other common cancers still has to take place, and high-risk screening in hereditary breast cancer patients. So needless to say, moving forward, we are getting some concerns raised by the family physicians who do think that they need to have a bit more information, education, and support, particularly with accessing us back for help. And so we have to develop new communication strategies, common health records, treatment summaries, and survivorship care plans, which is all part of this ongoing plan. We're certainly not there yet. With respect to education and training, I think that some of our national bodies have really done a good job in developing programs for us. The Canadian Association of Nursing has web-based learning modules for survivorship, the Canadian Association of Psychosocial Oncology as well. Family medicine is starting, but I think the specialists are lagging a bit behind in terms of developing a curriculum for survivorship. The issue here is these are all unidisciplinary curricula, and really moving forward, we're really talking about an integrated, interdisciplinary model of care, and I think the education then needs to follow and model that particular model. We haven't seen that happen as yet. So in the remaining part of the talk, I do want to talk about a little bit about the fourth platform, which is survivors taking responsibility, which really has been the focus of the Princess Margaret survivorship program. And we're really focused on building the capacity for self-management amongst our patients. Now we see about 50,000 new patients a year. Survivorship hasn't been front and center on the agenda, but certainly empowerment for patients during the diagnostic and treatment phase has been. And so we've been able to leverage some programs and services and start to embed the survivorship curriculum into those systems. So these are really all the platforms that we've been working on, and I'd just like to highlight one or two of them. Empowerment through education. Well, before I do that, just to say that in 2006, we put in a grant for a federal grant and a provincial grant for innovation. And we really pitched the idea of building capacity amongst cancer survivors. And we were funded to build a center. The center we called ELIXIR, the Electronic Living Laboratory for Cancer Survivorship Research, but we just call it ELIXIR. And it really is a health, wellness, and cancer survivorship center that we're able to build actually within the hospital. And so it's because we have the physical space now that we've been able to build out various programs. So there we have researchers interested in this area, clinicians, educators, and cancer survivors. And the space is able to accommodate self-management strategies in exercise, diet, and psychosocial support. So our goal really is to empower cancer patients and their families to become experts in the management of their own symptoms, health, and wellness. And to do that, we're going to have to figure out how to integrate effective self-management support into our clinical programs and systems. We want to also harness the power of survivor communities to drive and accelerate innovation in survivorship programs and services. Who knows better than the survivors themselves? And there's an awful lot of NGOs in cancer support in our community that we partner with to move our programs forward. So I've said empowering through education really is our mantra: information, education, tools, and support. And we piggyback the survivorship agenda onto this agenda. And we've got a space now so we can start to move the education and the classes over to ELIXIR. And just the table on the left here, I just want to highlight one or two of these survivorship initiatives. Getting Back on Track is a group class. It's a general class to explain to patients at the end of treatment what to expect. These are starting to be taken by various site groups and contextualized to very specific teaching, such as in the head and neck cancer. You can see that class attendance over the years has been increasing, and we're up to about 2,000 people coming over to the center last year for classes. But I've told you that we treat 15,000 new patients a year. So the problem here is, what are we going to do to extend our reach? This is a very limited approach. We'll not be able to reach quite a lot of people. And so this is driving basically the agenda to have a virtual ELIXIR on the web, starting to think about how we can have mobilize YouTube, social media, mobile devices as well. And so in endometrium and testicular cancer, we've taken that class and we've modified it for a web approach. And it's just sort of the start of building these programs and services. Same with our kitchen program, our healthy eating program. We've hired through a grant a chef and a dietitian, because it isn't so much telling people what they have to eat, it's showing them how to buy, what food to buy, how to cook it, how to make simple, effective recipes. and then how to build a community around food that people can start sharing and teaching each other. And so this particular microsite, the elixirkitchen.ca, we're having live stream videos of the teaching classes. We're having small, short excerpts. We're developing blogs, and we're trying to build out a survivorship community online. And this would be our test model. In terms of delivering self-care clinics, in breast cancer, we've developed a lymphedema, fatigue, neurocognitive, and function and mobility clinic. And this really was in response to us asking our patients what their major challenges was. We do a consultation for survivors. We've done about 2,200 now in the breast cancer community, and this is just at the early days showing what problems that they were facing, and it supported what we hear in the literature. 3/4 of them having some kind of physical problems: function and mobility, strength, fatigue, lymphedema were the issues. Psychosocial issues, fear of recurrence, anxiety, and cognitive problems post-chemotherapy. The social impact was around appearance, body image, family distress, and issues around going to work. And the spiritual impact had a lot to do with the meaning of life and uncertainty about the future. So those things drive how we decide what programs to develop. And using the chronic management model, we're looking at problems that are not very complicated, that people can be taught how to manage themselves, that are very common. And that's our framework. If it gets more complicated, we're looking for rehab centers and other programs and services to take care of them. We were overrun with lymphedema patients, and so we started even a general awareness class to see if we could help people who were mostly worried and wanted some prevention strategies. We've done that in fatigue as well as in the neurocognitive area. Just to show the difference between a class and a consult in terms of the chemofog clinic, the goals for the class would be very general, and they would be very general tips. The actual neurocognitive consult, it's a one-on-one assessment. It's looking at their particular issues. It's specifically designed to increase knowledge, improve their confidence, to self-manage, to help them create a personalized plan, and to decrease the emotional impact of this on their lives. We've done some work to see if that has been effective. And this data shows that we've done pre-post test, and then later on, 3 months later, to see if there's any sustained impact. And knowledge is increased, statistically significantly increased. Self-efficacy, which means confidence in their ability to self-manage, is increased. And their distress is decreased. But most importantly, it's sustained over time with a simple 1-hour intervention. We do have a research platform where we're trying to develop effective interventions right now. So far, they've been psychosocial, psychoeducational, but we've started to develop an exercise platform, and we're building out the nutrition platform. We do have partners in the biological sciences to help us identify mechanisms underlying the long-term effects. We're looking at evaluating models of care, and we're developing e-health systems and tools. I really want to acknowledge the support of the Princess Margaret Foundation. This is our philanthropic arm for the majority of the funding, which we leverage against research grants, the collaboration of all the NGO cancer support groups in the community who help us move forward, and a large interdisciplinary team of clinicians, educators, and scientists. Thank you.
Thank you very much, Dr. Keating. And I'll also just mention that we're so pleased to be able to work with Princess Margaret and with Dr. Mary Gasper-Arowitz, who's also our president. Most of the work on global cancer in the world through the UICC and happy to serve with her. We are a little bit over time, and we will have some time for dialogue at lunch. So I'd just like to take one question from the group. Carla.
Thank you very much for the presentation. For Nancy, I wanted to ask you, for the results that you showed of the program where you trained from Moderador here in Mexico, you showed there is no differences I could see from the y-axis in the increase of knowledge, although we see quite big differences
numbers, they were much larger because the baseline was lower. So yes, what I showed was statistically significant, and I will also add that other aspects of breast cancer knowledge and awareness and understanding of resources available for patients, et cetera, also significantly increased with the training.
So move us to the next session now, and just say that Drs. Keating and Patton will be with us for the whole day, so we'll have lots of time to be able to interact with them. Thank you very much.